So a little bit of background about me before I start the talk. So I trained as an interventional cardiologist. I've been qualified doctor now since 2001. And in the last few years, I've shifted my practice from intervention to prevention. And by the end of the talk, I think hopefully you'll understand why that is. I have a number of different roles. I'm speaking today here in a personal capacity, but I do a number of different things. I'm a trustee of the King's Fund, which is an independent health think tank that advises government on health policy. And I have also done a lot of work with the Medical Royal Colleges, which is the umbrella organisation that represents pretty much every doctor in the UK. So a lot of my work has been private advocacy, but also public advocacy as well, just to try and change our approach to how we manage this chronic disease burden. In terms of declarations, I have written a book called The Pioppi Diet, but I give all personal proceeds from sales of the book to charity. So I want to start by, I think what would be very good to illustrate the science is a case study. I think case studies are always very interesting, and this is probably the most interesting case study of a patient I've ever seen. So Tony Royle came to see me a few years ago. His background was he's a 55-year-old international airline pilot working for Virgin Atlantic. Very active. So this is a man that was running lots. He was doing triathlons for many, many years. Wasn't following the worst diet, but certainly wasn't following the best diet either. He was following a kind of conventional low-fat diet. So he had a health check done 2014, and his BMI is high. His waist circumference is 38 inches. His total cholesterol to HDL ratio, which I'll explain in a second, which is when it comes to cholesterol, the most important marker to determine risk of disease, was 5.3. Anyway, he gets a routine check, and he's found to have a risk score of having a heart attack or stroke of about 12.86% in the next 10 years. And unfortunately, a few months later, he suffers a heart attack. And luckily, it wasn't what we call a massive, significant myocardial type of damage heart attack, but he has a heart attack. It's life-changing for him. And he has one of his arteries is completely occluded, and he has a stent inserted, but luckily no impairment of his left ventricular function. So the damage to the heart muscle was minimal, which was good. Now, because he's had a heart attack, he can no longer fly. And having been an international airline pilot for 14 years, he then goes back to his previous job, which makes him a quite unique patient with what I'm about to tell you, is that he's a maths and physics teacher. So he's good with statistics and he's good with data. So he gets put on the usual cocktail of drugs that we prescribe patients who come in with heart attacks. And the conventional way we practice this as cardiologists, I'm not saying this is the right way, I've been that person. They come in, you treat the patient in the middle of the night, he has a stent, you do the ward round the next day, you tell the patients, please take these drugs religiously, they will save your life. That's pretty much the end of the conversation when it comes to the medications. And then of course there are some slight, some discussions about lifestyle. He gets prescribed this cocktail of drugs, and over a year later now, just over a year later, he starts feeling not very well. So he's got a lot of different symptoms. He's suffering from reduced energy, erectile dysfunction, he's got memory disturbance. His quality of life is significantly impaired. He's carried on doing his exercise, but now he's getting poor recovery from exercise as well. So he starts looking at the literature, he starts reading the side effects, he thinks, is there side effects, what else is going on? And he decides that he's going to stop his beta blocker and his statin a couple of months later. Now, he stops, these drugs, and within weeks, he feels like a new person in every respect. Completely, having felt really quite poorly for a few months, within a couple of weeks, stop those two drugs, he feels pretty, amazing, feels like a new man again. Around the same time, he'd been looking at research, he's noticed that his weight hasn't changed much, he doesn't feel that, he's in a better position to reduce his heart attack risk intuitively. He's been put on these drugs, he's looking at the medications. He's also looked at the fact that he's realized that all of the medications, the chances of benefit in him as an individual is very small, something that most doctors don't even fully comprehend, and certainly is not something that they translate to patients. So he's informed himself on that. But at the same time, he's started looking at research, he's read stuff I've been writing in the newspapers, some stuff in medical journals, he's heard about Professor Timothy Noakes. He decides to try low carb. So he basically specifically cuts out the ultra-processed junk foods, the sugar, the cakes, the biscuits, the starchy carbs, and he replaces it with lots of non-starchy vegetables, full-fat dairy, eggs, cheese, mixed berries, nuts, etc. That's all he does. He doesn't do anything else. His exercise is exactly the same. And within 3 months, he's lost 3 stones in weight. His waist circumference has gone from 38 inches to 30 inches. His total cholesterol's gone up, but his profile, if you remember it was 5.3 before, has improved, okay, 4.4. Now, during this time, he then decides that he wants to stop all his medications, having looked at it. He stops all his meds. This is when he comes to see me. So he comes to see me to tell me this. So I'm obviously a cardiologist, seeing him privately. He comes to see me. He tells me his story, which I thought was very interesting. He's made an informed decision. He's had a stent. He's off all his medications. And he says, the real reason, so I want to have a conversation with you. I've heard you're kind of a progressive cardiologist. You're not going to shout at me and saying, why you're not taking a statin or you will die, which is what he's been told by other doctors. So we have a conversation, but he says, the real reason I've come to see you, doc, is I want to know whether it's okay for me to do Ironman. Right? So imagine this, right? Cardiac patient, has a stent, has a heart attack, stopped all his meds and wants to do Ironman. I thought, wow, this is fascinating. So I had a conversation with him and I explained to him, actually, I said, listen, you know, what are the reasons for you wanting to do Ironman? Because if it's about longevity, if it's about reducing heart attack risk, you're probably increasing it slightly, you know? The data tells us that there is probably an optimum level of exercise on average, and for certain people, certainly doing too much could be a risk to you, but I say, you know, you're probably going to be okay, but there's probably increased risk. And he says, listen, it's something I enjoy doing, I want to do, I feel great, it's really important to me. I said to him, okay, let me just have a conversation about the medications. I think you should probably go back on aspirin, and why not try a low-dose statin? The data, my experience shows that people are much less likely to get side effects from statins, and it may give you some benefit, but those benefits are still very small. He says, listen, I'll have a think about it. So he goes away, 2 weeks later he calls me up and he says, doc, I've had a think about all of this. I've decided I'm going to carry on purely with a lifestyle approach and I do not want to take the medications. I feel great, you know, and it's true, all his markers were fantastic. You know, he had no markers of pre-diabetes, his waist circumference was down, he has normal blood pressure, etc., and he feels very good and he's exercising. Now that brings me on to the most important slide, I think, of my talk, which is this one. Now, Professor David Sackett, who's considered the father of the evidence-based medicine movement, this was published in the BMJ in 1996, and I want you to understand this concept because understanding this, in my view, explains much, if not all, of what is wrong with healthcare right now. This is at the root. We are not actually practicing evidence-based medicine. So let's just talk through it a little bit. So what is it, you know, what do we want to do as doctors? What do patients want from us? They want improved outcomes. Of course, that's what we want. But to do that, you use your individual clinical expertise, okay, or as a healthcare practitioner, your experience, of course, in seeing patients. You want to use the best available clinical evidence. And last but not least, take into consideration patient values and preferences. Now, if there's something wrong here, if the best available evidence is actually biased or corrupted, that's going to give you bad outcomes, or certainly not optimal outcomes. And if you're not taking patient values and expectations into consideration, what you do and what you prescribe is also not going to work. You know, say a patient really wants to do a lifestyle approach, but you're prescribing a pill, then, you know, how long are they going to take the pill for? So we've got to think about this a little bit more. And just to put things in perspective before I move on to the next slide, somebody I consider to be the Stephen Hawking of medicine, Professor John Ioannidis, who's Professor of Medicine and Statistics at Stanford University, his own estimate suggests that most of the published research that doctors have been using for decades to make clinical decisions is false. Most of it, 85% of it. One of the barriers to changing that system is most doctors don't know this. Okay, so this is, I give these talks and somebody says, you know, we're talking about statins, we'll talk about statins in a minute, but my doctor says this and my doctor says that. And I say, well, listen, don't blame your doctor, he doesn't know this. He doesn't realize that the information he's getting is flawed and far from optimal when it comes to making clinical decisions. What else did Professor David Sackett say? He said, half of what you learn in medical school will turn out to be either outdated or dead wrong within 5 years of your graduation. The trouble is nobody can tell you which half. So you have to learn on your own. I wish I had actually learned this at medical school because I would have been very skeptical about everything I was learning there. But so what I'm going to go through now is explain what I've learned, certainly in the last few years, when it comes to management of heart disease. Now, traditionally, high cholesterol, everybody in the world knows about cholesterol, and 99.9% of the population fear cholesterol and think you need to lower it. Why is that fear? What are the roots of all of this? Well, the framing study was actually the root of all of this. And this was a study that was carried out over several decades in the town of Framingham, Massachusetts, and they followed up over 5,000 people, and from that emerged various risk factors associated with disease, in particular heart disease. And what's interesting about Framingham when we look at cholesterol, now if you look at the graph on the left, ideally, when it comes to looking at a marker, we want something that can tell us what's going to be in a healthy range and what's the abnormal range. Now, with framing, what's interesting is the people who developed heart disease versus the people that didn't, they overlapped quite considerably. And actually, when you look at Framingham data in more detail, you find that people with genetically very high cholesterol, something known as familial hyperlipidemia, which affects about 1 in 250 people, there is a very strong association of premature heart disease. At the other extreme, people with genetically low cholesterol, by the way, most cholesterol is genetic. It's something we make in a living. We can influence it by diet, certainly, to various degrees, but most of it is genetic. So the other extreme, people with cholesterols of less than 3.8, they tended to not get heart disease. But in the middle, which is more than 90% of the population, your total cholesterol did not tell you who was going to get heart disease and who wasn't. It was a very poor predictor. Now, what else is really fascinating, everybody, most people, and certainly in healthcare, know that LDL cholesterol is a so-called bad cholesterol. That's the problem. But even from Framingham, William Castelli, one of the co-directors of Framingham, in 1996 published an atherosclerosis, and he said this, he said, unless LDL is more than 7.8 or more than 300, it is essentially useless in predicting who's going to get heart disease and who it is. Now, I rarely see, unless the patient has FH, familial hyperlipidemia, most patients, I'm sure all of you here, I suspect nearly all of you here, nobody will have their LDL that high. Yet we are being told, or the population and practitioners are telling patients and prescribing drugs to get LDL. In fact, create a fear, even if it's above, even if it's above 3. I see patients who are scared because their LDL is high. Now, let's muddy the waters a little bit more in a second, but what did Framingham actually determine? When it comes to cholesterol, the total cholesterol to HDL ratio is actually what predicts heart disease from cholesterol. And if we look at the hierarchy, so we've got cholesterol as a risk factor, but where does it actually feature in terms of LDL, etc.? Where does it feature in the hierarchy of heart disease? It's actually much lower down the list. The most important factor, this is a mathematical modeling study that was published in Diabetes Care in 2011, found that insulin resistance, which was most important, then high blood pressure, then BMI, then low HDL cholesterol, then low HDL, then BMI, then LDL were the most predictive in that hierarchy. And what's interesting, when they wrote this paper, they concluded insulin resistance is the most likely important single cause of coronary artery disease. A better understanding of its pathogenesis and how it might be prevented or cured could have a profound effect on coronary artery disease. What they're saying is, we don't know what causes insulin resistance and we don't know what to do about it. Right? They're writing that in 2011. Let's muddy the waters further. I was involved in this study. I co-authored it with several international scientists, and we decided we want to look at what is the association. What else Framingham found is that after you hit 50, there was an increase in mortality as cholesterol dropped, which really couldn't be very well explained. Some people say it's to do with illness, but actually this went on for many, many years before people got sick. So there was something else going on. So we thought, let's look at LDL in isolation and do a systematic review to find its association with heart disease and how strong it was. Is it a weak risk factor? How strong is it? We were kind of surprised in a way. There was no association at all. There was no association with LDL cholesterol and heart disease in people aged over the age of 60. And an inverse association with all-cause mortality. In other words, the higher your LDL, if you're over 60, the less likely you are to die. One of the explanations for this is cholesterol has many roles in the body, and it's also involved in the immune system, and elderly people are more vulnerable to dying from things like infection, pneumonia, etc., gastrointestinal illnesses, and it may well be that's a protective mechanism. And I remember shortly after this was published, and I ended up writing about this in the Telegraph newspaper, a patient came to see me in my NHS clinic. This lady came in her early 60s, and she walked into the room and she looked really terrified. She was really worried, almost like white as a ghost. And I said, "What's wrong?" She says, "I'm really worried. My GP has told me my cholesterol is high." And I said, "Congratulations. You're going to live longer." And I explained it to her, and she left the consultation with an informed decision-making conversation. She did not fear her cholesterol being high anymore. She didn't need to. So 2013, having looked at all of the evidence up to that point in terms of saturated fat, et cetera, I determined that we were focusing on the wrong nutrient, that this was not, there was no significant evidence suggesting saturated fat caused heart disease. We had neglected sugar and refined carbohydrates, and I published this editorial in the BMJ, but I had to put the jigsaw together, because if saturated fat doesn't cause heart disease, but we know it raises cholesterol, that means cholesterol isn't that important. But if cholesterol isn't that important, how do statins work? Why do statins reduce mortality? So I was able to put all of that jigsaw together and explain it. And when you look at the, and I also, in terms of what I understood, again, looking at all the information when it comes to cholesterol-lowering trials, statins effect, and this is well known in the published literature, statins effect are also independent of LDL lowering. So they probably have some anti-inflammatory effect. How effective that is, the size of the effect we'll discuss in a minute, but it's probably, their mechanism of benefit is probably through an anti-inflammatory mechanism, not because it lowers LDL cholesterol. So I wrote this. What I didn't expect was the huge media interest that then developed after this editorial was then press released by the BMJ, and it became a global story. So the next thing, I'm front page of 3 British newspapers. I think the Times newspaper were quite happy that a cardiologist says butter is back. So that was their headline. I was on BBC News, I was on Fox News Chicago, I was on CNN International, having to really defend this. So let me just quickly explain. A lot of you know this already, but let me explain essentially what I said. Well, we know that dietary advice changed in the 70s in the US and in the UK because Ansel Keys, an American scientist, correlated from 7 countries the association of saturated fat consumption and heart disease. But he was selective in his data, which we found out later on. That changed the dietary advice. Low-fat foods, high sugar, high refined carbohydrates then became very prevalent within the Western diet. Of course, there's then been a correlation in increase of type 2 diabetes and obesity. I think that the evidence is very compelling that it is causative. This is actually behind the root cause of the type 2 diabetes and obesity epidemic. And of course, Keys, for whatever reason we don't know, he left out other countries that didn't really fit his hypothesis. And when you add other countries in, that correlation, which was not a strong correlation anyway to start with, became much weaker. What I didn't know till a few years ago, Ansel Keys also received funding from the sugar industry. Around the same time, British nutritionist John Yudkin said it was because of sugar. Sugar was a problem and the cause of heart disease, but Keys won the battle over Yudkin. And the sugar industry was very powerful, and Yudkin disappeared until Robert Lustig came along a few years ago, and now obviously sugar is now a really important public health issue, and is being tackled very well, I think. So, we'll carry. So what about saturated fat? Well, yes, okay, saturated fat can raise LDL to different degrees, but what it also does is it raises HDL. So the overall effect in most people on average is, at the very least, it's a neutral effect. It does not worsen your total cholesterol to HDL ratio. And that, if you remember, is what we use in risk calculators. So that's probably why it is not associated with heart disease when you look at most of the studies. Now, interestingly, there have been some associational studies that suggest that saturated fat from dairy products could be protective. I'll come on to that in a second. What else is the problem with the whole approach to cholesterol? Well, a re-examination of the Sydney Heart Study, a randomized controlled trial, which basically took cardiac patients who ate butter versus ones that ate margarine, despite lowering cholesterol, eating this margarine, safflower oil containing margarine, by 13%, there was an increase in all-cause mortality and cardiovascular mortality in the people that lowered cholesterol. So think about this for a second. They lowered their cholesterol, but that group, and it's probably through a pro-inflammatory mechanism, had increased mortality. And that reminds me, a really good line from a colleague of mine, Rita Redberg, editor of JAMA Internal Medicine and professor of cardiology in UCSF, California. She says, cholesterol is just a lab number. Who cares about lowering cholesterol unless it actually translates into a benefit for patients? So that's what we need to think about when we're approaching cholesterol as well. Why are we lowering it? What are we lowering it with? What is the evidence of benefit? Is that patient getting that information in a transparent way? And essentially, after my editorial, Cambridge Medical Research Council and the BHF did a huge study looking at all RCTs and observational studies. using a total participant number of 600,000, and this is fascinating, and they basically found that they couldn't recommend anymore that there was a reducing saturated fat would actually prevent heart disease. That still hasn't got itself into the mainstream yet, interestingly, despite many other studies confirming this later on. And they found an interesting finding was that a particular type of saturated fat, a margaric acid, which is a dairy fat, there was an association with a reduction in cardiovascular disease. So this might explain the French paradox, where we know the highest consumption of saturated fat in Europe is in France, 15.6% of calories. And I remember as a junior cardiologist going to all sorts of conferences, and there was almost this feeling amongst the cardiologists. We would always present data about our mortality data from heart disease, and our gold standard was France. We need to reach France. France have got this, this is fascinating. Despite probably having more smokers in France as well. So I think there could be an explanation, there could be something in dairy that's protective. Ultimately, the take-home message is that we should really be concentrating on whole foods. That's what we should be doing. Now, let's come back to statins again. This has been the most prescribed drug, one of the most prescribed drugs in the history of medicine, certainly one of the most lucrative drugs. It's estimated by 2020 total sales of revenues of statins is going to reach $1 trillion. So this is the drug that we have used and cardiologists use. This is a blockbuster, amazing drug that's going to end heart disease. It was predicted to end heart disease when they were first prescribed several decades ago. But has it actually happened? No, it hasn't. But let me just explain very quickly. When you're looking at low-risk patients, so if I'm having a conversation with my patient about statins, I speak to them in a transparent way for them to make an informed decision. John Abramson in Harvard published in the BMJ and said a reanalysis of published data, which by the way is still industry-sponsored data. It's not new data, it's reanalyzing published data, so there's a big caveat here. But what we find is if you're at low risk, statins are not going to prolong your life by 1 day. Most people in the world, maybe 100 million people prescribed statins, are not in a category that's going to improve their mortality based upon industry-sponsored data that is probably already biased. Okay? There's no prolongation of lifespan at all. But there's about a 1% chance that it will prevent a non-fatal heart attack or a non-disabling stroke. Okay? So this hasn't been questioned, this hasn't been rebutted. Side effects are probably much higher. So John Abramson wrote, this became controversial. I won't talk about it in this talk today, but there was a big controversy around the side effects. And he said 20% of all patients taking statins, including what I wrote about, will experience some sort of side effect that interferes with quality of life. Now, what about if you're high risk? What if you've had a heart attack? What are the benefits for individuals there, looking at all the data? It's about 1 in 83 for mortality. So patients come to see me, and I have an informed decision-making conversation. This is what Tony Royle read. Tony Royle, the patient who decided to stop his statin, he is aware of this. And based upon this, he made a decision that he would not want to take a statin. About 1 in 40 chance it will prevent a non-fatal heart attack, 183 mortality, and about 1 in 125 for stroke. And I think the side effects are probably higher than this. I'll explain that in a minute. Why is all of this important? This is important because if you do not tell patients this as a doctor, you are not practicing ethical medicine. You are not practicing ethical medicine. Don't just take my word for it. 2009 World Health Organization bulletin from the world-leading researcher in health literacy, Gerd Gigerenzer, from the Max Planck Institute in Berlin. He wrote, this is online, you can see this. He said it is an ethical imperative that we explain to patients the difference between absolute and relative risks to protect patients from unnecessary anxiety and manipulation. In other words, unless doctors have this conversation with patients, they're actually being unethical. I've said this before, I will say it again. What's the problem with statins? Why have they not reduced cardiovascular mortality? One of the problems is this. Most patients stop taking statins within a year of prescription. This is before any so-called media awareness or scaremongering of side effects. Remember, I was that doctor, prescribed statins, do not mention side effects at all because we think they're non-existent, they're very rare. So this is the reason. Now, another bit of conventional wisdom, and I've had conversations with various people about this before, but Aseem, statins have reduced cardiovascular mortality in the population, certainly in the high-risk groups. We understand low-risk patients with heart disease. Have they? Is there any study that has specifically looked to answer this question? Yes. BMJ, 2016. They found, looking at statin uptake over many different European countries, over 12 years, there was no reduction in all different risk groups based upon prescription of statins in cardiovascular mortality in the population. No reduction. Now, is it because the data's fraudulent? No, I don't think so. You can explain it scientifically. How can you explain it? Do you know what? So if you're prescribed a statin, if you look at the statistics differently and take an average across the people in the randomized controlled trials, selected patients in randomized controlled trials who didn't get side effects, and they take a statin, how much longer would that group on average, what would be the increase in life expectancy over 5 years in the people who have had heart attacks? Most patients, when you ask them, would expect, what would you want? Some of you may know the answer to this, but as a patient, just shout it out. If you were told by your doctor, you've had a heart attack, you don't want this to happen again, you want to live longer, over a 5-year period, if you take this pill every day, how much extra would you want that over that 5-year period for it to add to your life expectancy? 10 years. Any other takers? How much would you want for you? What would you hope for? Okay, 20% increase, so yeah, okay. A couple of years, okay. 1 year, sorry, 1 year. Bad maths. Okay, well the actual answer is you're right, it's 4 days. The actual real answer, when you look at the data from industry-sponsored studies, which is selected in patients who don't get side effects, it's 4 days. Now that explains because 50% of patients, even in secondary prevention, will stop taking their statin within a couple of years. And when you ask the patient why, it's because they suffered side effects. The contrary to this argument is people talk about the nocebo effect. Patients are basically imagining it. Yes, that exists. But for statins, the real cause for them stopping it is because of side effects. Now, remember the first slide, best available evidence. We have a problem right now of misinformation because of publication and publicity bias. Most doctors get a lot of information, patients and doctors get their information from news stories, not necessarily from medical journals. And if they get it from medical journals, they're often not privy to other studies because they're not well publicized that contradict the very study they're reading. There have been 44 randomized controlled trials involving diet and drugs that showed no benefit on mortality. Most of them showed no benefit on reducing even heart attack, cardiovascular events, and many showed harm. And there's nothing to say there's something wrong with the quality of these trials. So this is a problem. Now, why have we failed in tackling heart disease? Hopefully I've given you some insight when it comes to cholesterol and statins, but there is an indirect effect of this reductionist approach to cholesterol, is that we have now prescribed this drug to millions of people who are at low risk, who aren't going to have prolonged mortality. They're also going to get type 2 diabetes, by the way, a lot of them, because 1 in 50 maybe get type 2 diabetes. Statin users mistakenly think they can eat what they like. And of course, we've got this whole mantra with the food industry as well, proven to lower cholesterol foods, high refined carbohydrates, et cetera, et cetera. And it's stopped us focusing, I'm going to come onto this shortly, the shifting the paradigm, other preventative strategies. This picture speaks 1,000 words. I have seen many patients that have the illusion of protection. They come in, my cholesterol's great, I'm taking a statin, that means my risk is fine, it means my diet's okay, I might be overweight, but maybe that's lack of exercise, but I'm fine. I can eat what the hell I like because my cholesterol is fine, because I'm on a statin. Absolute unscientific nonsense. It is very sad that we of the profession have been complicit in this rubbish for such a long time, and people suffer because of it. So, Aseem Malhotra, several years later, rather than being the controversial cardiologist on his own, saying that we've got it all wrong, I, through my private advocacy, through my conversations, through my emails, I co-opted in Professor Rita Redberg, editor of JAMA Internal Medicine, practicing cardiologist, and Pascal May, editor of BMJ Open Heart. And we said, listen, all of this data is here. We need to change this paradigm. We need to shift towards the underlying root cause of heart disease. So we wrote this editorial, peer-reviewed. It broke records. I'm glad that it's got interest because for me, this is about getting the information out. So it's like 1.4 million views now in the British Journal of Sports Medicine. But that's good because it's generated that much interest from it, and there's not been really any effective rebuttals. But this is really the root of it all. When you look at the data that's there, and listen, science evolves, better data may come out, but at the moment it's quite clear that heart disease is rooted in insulin resistance and chronic inflammation. And if we target insulin resistance and chronic inflammation, not only will we reduce cardiovascular disease, but we'll also, about 50% of hypertension can be attributed to it. Of course, this is a precursor to type 2 diabetes. So these chronic diseases, all the risk factors, major risk factors other than smoking for heart disease. Now, I have chosen, from my analysis of the data, a diet that is anti-inflammatory and also low in refined carbohydrates. So I say, that really a high-fat Mediterranean diet based upon extra virgin olive oil, nuts, oily fish, etc., based upon their biological effects in terms of inflammation, by cutting the carbs, I think this is probably the best dietary approach for this, for tackling heart disease. And of course, we must not forget these other lifestyle factors, so crucial. And I think there'll be a lot more evidence emerging from more rigorous data about stress reduction. Psychological, stress is a big factor, and it causes insulin resistance and it causes systemic inflammation as well. So I think not being sedentary, just walking 30 minutes a day, doing something in terms of moderate activity is very effective for reducing insulin resistance, and it's about stress reduction as well. And then I wrote a book called The Pioppi Diet around the same time. Thank you, 5 minutes left, almost there. This is good. To really bust these myths that I think were so prevalent in the modern day. And it's based upon a southern Italian village where I went and made a film called The Big Fat Fix with my co-producer Donal O'Neill, who's an international athlete. And really the most important message, amongst everything else I've told you already, is that dietary changes, the evidence is there, are more powerful at preventing and treating heart disease. And certainly their effects are rapid when you think about how this can affect people in terms of people who adopt a certain lifestyle pattern. This is just one example, a patient that's posted on my Facebook about how essentially he'd reversed his metabolic syndrome. Most people admitted with heart attacks, I must emphasize, have metabolic syndrome, insulin resistance syndrome. And he managed to lower his blood pressure and send his type 2 diabetes into remission within a few months of changing his lifestyle, essentially following a low carbohydrate type of diet. Private advocacy work I knew was going to cause a lot of controversy. I'm not going to talk about that much today, but there is a lot of controversy about some of this stuff. Mainly coming from very powerful vested interests who aren't very happy that I'm saying cut out the starchy carbohydrates. But I had the Mayor of Manchester, former Secretary of State for Health. Sarah Cox is a well-known BBC broadcaster here. I don't know her. She contacted me out of the blue. She's never been particularly overweight, but said that she felt great, when she changed her diet, adopting my dietary plan. And of course, I ensured that, again through private advocacy with people who are not naive or stupid, that we need to change this understanding of how we're managing patients in terms of tackling obesity. So the chair of the Medical Royal College is arguably the most important doctor of the UK, endorsed the book. The Queen of England's personal physician for 21 years, Sir Richard Thompson, all endorsed the book. And for me, the most important thing wasn't to sell 1 million copies, it was to make sure we influence health policy. So this got announced in Parliament, in Hansard, in British Parliament. It is documented that the chair of the All-Party Diabetes Group, Keith Vaz, got up and told 100 MPs with the highest prevalence of type 2 diabetes in their constituencies to adopt this dietary plan to see what happened. And the most sort of prominent person, again, I didn't know this person, he contacted me, I had no personal relationship with him, and basically, Tom Watson is the deputy leader of the Labour Party, and he lost 100 pounds within a year, and he'd always struggled with his weight for a very long time. He tried every different diet and had fallen off the wagon, but he said this worked for him, and he's doing very, very well now. Now, what I didn't predict was that then, it got some international reach. A film company, a health program in Holland contacted me last year, and they wanted to do a trial N=3, okay? And say we're going to take 3 random people in Holland and put them on your dietary plan, and you claim it's going to have an effect on their risk factors within 21 days. We want to test that out. I said, fine, let's do it. I obviously couldn't predict what was going to happen. So these 3 patients, one with type 2 diabetes, on insulin, about to go on insulin, trained driver, a lady who'd had bariatric surgery and struggled with her weight, and a chap who'd just been diagnosed with heart disease and high blood pressure and pre-diabetes, all went on this plan in Holland. It was all filmed. They were followed up by their GP. And at the end of the 21 days, 28 days it was 28 days in the end, they were then given all their results in Pioppi. So we all went and took the filming crew to Pioppi, and it was amazing. The chap with type 2 diabetes came off all his meds and sent it into remission within a month. The lady with obesity lost 10 kilograms very easily, but was amazed that it was from eating fat that she could do this. And the chap with high blood pressure managed to normalize his blood pressure. And then it was released, somebody sent me this from Schiphol Airport. The book was released in Holland around the same time. This was watched by 1 million people. And it went to #1. I was quite kind of proud about this, look at who's #2 here. It went to #1 for about 5 weeks until the Dutch Nutrition Council weighed in and basically started making all sorts of nonsense up about the book, saying things, this doctor's advocating more than 10 eggs a week, that's going to kill you, blah, 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 all that kind of nonsense. But anyway, it did well for a while. 1 minute left. So what does this all really come to ultimately? We need to use the best available evidence. We need to think about that more carefully and how we also translate that evidence into our patients. Lifestyle certainly is a route forward. And I think from, when it comes to being transparent with patients, actually, we've got this crisis of an over-medicated population at the moment. Some estimates suggest that the 3rd most common cause of death after heart disease and cancer is now prescribed medication, what your doctor prescribes for you. And this is because side effects are much more prevalent than what the information we're given from clinical trials. That's one of the reasons. So Tony Royle did his Ironman. I wrote this case study up in the Pharmaceutical Journal, and you can look at it, it's free online, everything what happened to him and his informed decision making. He said this is all very ethical, actually, this is actually the best way to practice medicine. For this chap, this is what he wanted to do, and it was fine. This is a heart attack patient. Most cardiologists would be up in arms about it, but this is an ethical way of practicing evidence-based medicine. And it would save money, because actually when you fully inform patients, many of them choose not to take a drug or to undergo an operation. And that was, it hit the front page. It was in The Guardian as well, reported in The Guardian, and it was the front page of the Daily Express newspaper. But essentially, yes. I mean, if we're really going to curb heart disease, then it's going to come through a lifestyle approach. And Christian Barnard, who is perhaps regretfully at the end of his career, he's a pioneering heart transplant surgeon, said, I've saved 150 lives from heart transplantations. If I'd focused on preventive medicine earlier, I would have saved 150 million. It turns out lifestyle is that medicine. Thank you very much.